I got the elevated train right behind me. You can see the L in Chicago. I hope you guys are doing well. With the altered time frame, I was going to record kind of late here, so I wanted to make these tapes for you guys. But it's a perfect time to do some joints. So perfect time, let's do some joints. Now, what do when you see a red, tender, swollen joint? Well, one thing you don't want to miss is an infected septic joint. If you miss a septic joint, it'll destroy their joint and they'll lose their function forever. And that's going to be your fault. So the rule is if you see a red, swollen, tender joint, you want to tap it. So wouldn't it be a perfect pickup line? Right? Then you remind me of an inflamed, swollen joint. Why? Because you make me want to tap you. Don't write it down. These lines will not work. But it's to emphasize the point that you don't want to miss a septic joint. So you gotta do a tap. Arthrocentesis is indicated when you see red inflamed joints. So put a needle in. Now we tap it, we want to see what do we find in the synovial fluid. And we're gonna kind of divide our thoughts into the following. We want to look for non-inflammatory processes, things like osteoarthritis, degenerative joint disease. This is a non-inflammatory process. You're basically wearing out the joints. Versus an inflammatory process like rheumatoid arthritis or gout or ankylosing spondylitis or reactive arthritis. Look, itis. These are inflammatory. Okay, so you have a much higher white count. And of course, we don't want to miss a purulent joint. A pussy joint, that is going to ruin the joint. That is something that's usually a pyogenic bacterial infection. If you leave it untreated, they will lose the function of the joint and it will be your fault. So very important to divide our synovial fluid finding into non-inflammatory, inflammatory, and purulent. And of course, you can also have a hemorrhagic joint. Somebody who has trauma to the joint, especially somebody with hemophilia. Hemophilia, coagulopathy patients, they often bleed into their joints. In that case, you expect to find lots of red blood cells. It's basically hemorrhagic. Again, we'll see it when you have joint trauma, so a football player, or you'll see it with a hemophiliac, okay, because they bleed a lot. And of course, the cultures will be negative. Okay, that's just a swollen, swollen, bloody joint. It's not really inflamed. All right, now let's come back here to a differential. Non-inflammatory, inflammatory, purulent. Now we're always going to start with the white count. So normally we should see less than 200 white blood cells per microliter of fluid. And of those white cells, less than 25% should be neutrophils. Okay, so most of the white cells should be lymphocytes. Now let's compare it to non-inflammatory. Notice the white count is up. It's more than 200, but it's not super high either. And again, it's usually less than 25, which is 25% neutrophils, which is normal. So just more inflammatory cells than normal, but it's not very high. So this is called non-inflammatory. When you look at the fluid growth, it's usually transparent like synovial fluid should be. You should see right through. And of course, the culture is going to be negative. We'll always do a culture and we'll do a fluid analysis. Now, for inflammatory process, when you have itis, inflammation, we expect the counts to be much higher. So somewhere between 2,000 and 75,000 white blood cells. That is pretty darn high. So that's inflammation for sure. And notice we're starting to see a greater percentage be neutrophils. So it's an acute inflammatory process. Now, when we look at the fluid, it can either be transparent or somewhat opaque, depending on how high the white count is. The higher the white count in there, the more opaque the fluid will be. Again, when you start seeing elevated white counts, we're starting to think about itis. We're thinking inflammatory processes. And again, the culture should be negative. And then finally, when we have white counts over 100,000, and it's mostly pus, it's most neutrophils, that's a septic joint. We expect the cultures to be positive, and we don't want to wait for the cultures. We'll send this fluid for culture, but we're not going to wait. We're going to treat it right away based on what we think it is. The most common organism is going to be staph, so make sure you cover staph. Okay, and we'll talk about the differential emission as like in a minute. But think about pyogenic bacteria, especially staph. Staph, remember staph for bone infection, joint infection, bone infection, joint infection, Staph aureus, Staph aureus, Staph aureus. Now, obviously, with this much pus, it's going to be opaque. It's going to be a fluid that clots very readily, clots right away, because it's all pus, it's all sticky. All right, so again, red swollen joints, tap the joint. See, is the white count elevated a little bit? That's not inflammatory. Quite a bit inflammatory, or through the roof, that's a purulent joint. And again, if it's just blood, that's a traumatic joint, either trauma in a healthy person or a minor trauma in a hemophiliac. A minor trauma, big bleeds. Okay, and if it keeps recurring, that can also damage the joint as well. So blood in there is going to have to be eaten up. Macrophages are going to have to come in. So recurrent hemorrhagic joints eventually get destroyed. Okay. All right, now let's talk about the different categories. So we're going to talk about arthritis first. A famous question is, does the student know the difference between degenerative arthritis, which is osteoarthritis, versus rheumatoid arthritis? So here's a nice summary chart just to keep it simple in our brain. So osteoarthritis is wear and tear. You're wearing out the cartilage. That cushion is getting just traumatized and destroyed over time. So it's wear and tear of the articulating cartilage. That's our cushion of our joint. So now I got bone grinding against bone because the cartilage is gone. Oh, that's going to be painful. That's going to be a burning, aching sensation. Now, which joints are going to wear out first? Well, weight bearing, ones that are bearing weight. So knees, hips, and spine. And it tends to be asymmetrical. One knee will burn out before the other knee. So this is called degenerative arthritis. And again, it's non-inflammatory. It's not caused by inflammation. You wind up with a little bit, but it's basically a non-inflammatory process. And that's opposed to an inflammatory disease like rheumatoid. Rheumatoid arthritis is an autoimmune, systemic inflammatory disease. So not only do you get inflammation of your joints, but you're also going to have problems systemically. So you can have rheumatoid factor antibodies present in your blood. You can get rheumatoid nodules of the extensor tendon. So that's outside the joint. You can also have attack of your heart, attack of your lungs. Other organs can be attacked too. This is an autoimmune disease where you're primarily affecting your joints, but other areas can be involved as well. Now, in terms of the joint, it's not the cartilage as much as it is the synovium. So this is a synovitis. That's our mantra. Rheumatoid is a synovitis. Inflamed synovium will eventually grow over the joint and cause a pannus. Pannus is a claw, and it will cover up the joint and mess up the joint function. So degenerative, you wear out your cartilage. Rheumatoid, you inflame the synovium. You inflame synovium, which creates a pannus. Now the joints that are affected are usually the small joints. Small joints, so the hands, the ankles. The most common is the MCP joint. MCP and PIP, these are commonly affected joints. But wrist, ankles, small joints, and it usually tends to be symmetrical. So both sides are usually involved, and it can be migratory. One day it's the MCP, next day it's the wrist, next day it's your ankles. So symmetrical and migratory, that's classic for rheumatoid, and clearly it's an inflammatory disease. Now, let's take a look at these in greater detail. Okay, I guarantee that one of the most common arthritides in the world is osteoarthritis. It's the most common joint disease. In fact, they estimate if you live long enough, if you make it to age 80, about 80% will have at least one joint involved. So if you make it to 80, you're pretty much guaranteed 80% of the time to have at least one joint involved. So pretty darn common. If we live long enough, we have a chance of wearing out our joints. Now, the synonym for this is degenerative joint disease. And again, the key lesion here is degeneration of that cushion. The articulating cartilage basically gets worn out. Now, what I mean by oligoarticular, oligo means only a few joints are involved. It's not all your joints. It's a couple of joints. One or two joints are going to wear out before the other ones. So it usually affects a few joints. Now, it's usually the weight bearing. They're most likely involved. So knees are a common site, hips, spine, and the hands, especially if you're like manual labor, doing a lot of things with your hands, you definitely wear them out as well. Now, risk factors here are aging. As we get older, we're more likely to wear out our joints. Genetic factors do play a role. Environmental factors. These are all can contribute to injury to the chondrocytes. So some important factors you need to know are some risk factors. So it could be secondary to trauma. If you're a football player, soccer player, if you're running a lot, you're going to get trauma to your joint, especially football players. Every play, there's going to be impacts. And over time, it takes a toll. Like Joe Namath, Broadway Joe, oh, you're too young to know this. Did you know the Jets actually won the Super Bowl? I know it's kind of hard to fathom, but they won it once, a long time ago before we were born. But the Jets won it once, they'll never win it again, but they won it once. Jets, Jets. They'll never win it in my lifetime, that's for sure. But Broadway Joe Namath led them to victory. Well, guess what? He got tackled so many times, both his knees had to be replaced. So very common for football players to need joint replacements over time to really wear out their joints. Another one is going to be diabetes. Why diabetes? Well, because neuropathy. You can't feel position sense. So if I lose position sense, I can't feel what position my joint is in, you're going to torque it and damage it, and you're going to wind up with degeneration. We call that a Charcot joint. Charcot, where you get neuropathy that leads to injury of joints. Hematidrosis, as I mentioned, if you keep bleeding in your joints, well, macrophages come in, you get granulation tissue, you get fibrosis, eventually you destroy the joints. So if you're going to be an orthopedic surgeon, you better learn your hemophilia, because that's what I wanted to be. I want to be an orthopedic surgeon, so I learned my hemophilia, and they were so impressed with me, because a lot of hemophiliacs will need joint replacements sooner or later. So if you know your hemophilia, they'll be impressed by you too. Ochronosis, remember that was alkaptonuria? Alkaptonuria, homogentistic acid loves the cartilage. When it goes there, not only does it turn black, but it's an acid. So it'll break down the cartilage and it'll degenerate. So black cartilage. So bluish-black nose, bluish-black ears, and early onset TJD. Hemochromatosis, iron can damage your joints. It's very common, by the way, for hemochromatosis patients that have joint problem because the iron makes free radicals. And of course, obesity. Obese patients are pounding their joints. They're pounding it. So remember, obese patients have a lot of aromatase, a lot of estrogen. So obese patients don't get bone disease. Like, for instance, they don't get osteoporosis because they got estrogen, but they do get joint disease. You know, it's like, oh, great, I can eat an extra brownie tonight. No, obese patients get type 2 diabetes, they get atherosclerosis, they get metabolic syndrome, they get joint disease, but at least they don't get osteoporosis. I guess that's one good thing. All right, now let's go to the clinical. We're looking for an insidious onset, usually in older individuals, 50s, 60s, 70s, of this deep, aching joint pain. Now they're going to say the more they use it, the worse it feels. So they always want to rest it. They want to rest it because it feels better. So the more they use it, makes sense. If there's no cushion, you got bone grinding against bone. The more you grind it, the worse they're going to feel. So a deep aching pain in their knee, it gets worse the more they use it. They want to sit down and rest. Now, morning stiffness will occur. They also get stiff in the morning, hard to get started, and they get this creaking sensation. So creaking, it's basically bone grinding. It's a grinding, grating sensation because you got bone grinding against bone. So creaking, cracking, grinding sensation, that's crepitus. And of course, they'll get a limitation in their range of motion because they're basically destroying your joints. Now, treatment here, we want to manage the pain. So using NSAID is very important. You want to do activity modification. So I want to keep active, but not overdo it. I don't want to damage the joint anymore, but I got to keep active. And eventually, unfortunately, since the cartilage does get worn away and it's not going to come back after a certain point, you're going to have to do basically hip replacements, knee replacements. You're going to have to do joint replacements eventually. So not a great thing to have. And by the way, hip replacements, big problem. Big problem. Because when the old people go in for hip replacements, they often never leave the hospital. They wind up getting other infections when they're in the hospital, they wind up dying. So breaking hips, not cool. Degenerative joint disease, not cool. Older people don't do well. All right, now here's the pathology. We're going to look for damage to the cartilage. So you're going to get what's called fibrillation and cracking of the matrix. So if we take a look at this picture, this is the cartilage layer right here. Here's the subchondral bone here, the bone below it. But this is the cartilage layer. Notice the way it's cracking. It's not normal. You see all these cracks here? So it's cracking, it's fibrillating, it's all breaking up here because you're wearing it down, wearing it down. Now you can also get chondromalacia as well. This is when the articulating cartilage tends to have it's called a granular appearance. So when you look at the surface, it's very granular. You're basically seeing these little breaking things, little granules here, little broken pieces of cartilage. That's called chondromalacia. Now eventually they'll lose the cartilage. When they do, you're gonna have bone hitting bone. So this is the microscopic. If we look at the growths, the white stuff here is the cartilage. Do you see how thick it should be? Nice thick layer of articulating cartilage. This is the head of the femur, by the way, femur. So nice thick cartilage. Now, as you go along, it starts getting thinner and thinner. Here it's thicker again, but here it's basically gone. There's no cartilage here. It's basically worn away. Now I got bone grinding against bone. It will become polished. We give that a fancy name. We call it eburnation. Eburnation. So the bone grinds against the bone, it becomes polished and smooth. We call it eburnation. So you lose the cartilage, the bone grinds and becomes polished, eburnated. Now underneath it, the bone tries to get thicker to protect itself. So you start seeing dense bone down here, dense bone, thick bone here, because it's basically trying to protect itself because there's no cushion. I got bone hitting bone, so it activates and reacts and becomes thicker. Now unfortunately, little cracks will occur in the surface and fluid will get injected from the hitting. The fluid gets injected into the cracks, into the bone, and you start developing cysts. So if we notice in this area here, we've got a cystic space. Looks like there's another cystic space here too. So these are called subchondral, below the cartilage, subchondral bony cysts. That's just a consequence of losing the cartilage, cracking the bone, and then getting fluid injected into the bone. Now, little pieces of cartilage may float around. We call them loose bodies. Little pieces of these cartilage break off. They call it loose bodies or joint mites. Now, loose bodies are nice, but not this kind of loose body. You don't want this one. Eesh, this is not good. This joint mice will float around, but eventually it could come back. It could float around here and then come back into the joint. When it comes back in here, a little piece will get wedged in there, and the joint will become fixed. And I had a great case when I was a resident. Guy came and said, I can't move my leg. It was literally fixed. I couldn't move it either. Then we went in with the scope, little arthroscope. We grabbed the piece of cartilage, pulled that loose body out from the joint space, and it opened, the joint started moving again. It was amazing. So those little loose bodies can cause trouble if they get wedged in the joint again. Now, at the edges of the bone, the bone starts to proliferate outward, and you get these little outgrowths of bone. We call them osteophytes. Lay people call them bone spurs, bony outgrowths. The bone is just reactively growing. So it's thickening, becoming denser, and at the edges it tends to grow outward. Now those osteophytes can impinge on nerves because they're growing outwards where nerves could be. There could be nerves on here and arteries. So it can impinge the nerve and get nerve pulses. Okay, so again, what do I need to focus on here? Well, focus on some of these keywords. I want you to have a loss of the articulating cartilage. It becomes granular and fibrillated. You're going to have eburnation. You're going to have sclerosis and bony cysts. You're going to have loose bodies, which can cause the joint to kind of lock up. And you can have osteophyte formation. These are the classic features of osteoarthritis. Now, osteophytes can get fancy names when they occur in different locations. Usually they just call them bone spurs. But when they occur in the fingers, they give them different names. Bouchard's nodes and Heberden's nodes. Now, I just remember like this. As I'm going along my body, we've got the proximal PIP and the DIP. Well, as you're going along, B comes first. Bouchard's is proximal. H, Heberden's, is distal. So Bouchard's and Heberden's. Oh, here's a good Heberden's. So Bouchard's is here, an osteophyte here at the PIP. Heberden's is at the DIP. See the way these bony outgrowth here? Bony outgrowth. Okay, that's Heberden's. Here's the Bouchard's. It's bony outgrowth, these osteophytes. Listen, it's just a $10 word for osteophytes at the PIP and DIP. Just $10 words, okay? Now, here's what it could look like on x-ray. Notice, here's the head of the femur, here's the socket. Notice the joint space here. I see the joint space here, but as you go along, the joint space gets lost because there's no cartilage. Remember, you're supposed to have cartilage cushion. There should be a space. But when you lose the cartilage, now I got bone hitting bone, you lose that space. So loss of joint space is very common on x-ray. And then you'll see these bony outgrowths at the edges. These are the osteophytes, where it's growing out at the edges. Okay, so it's a classic x-ray findings. Loss of joint space and osteophytes. All right, now here's a little just drawing of it. Notice the cartilage is getting worn out. Some of the fluid gets injected in, you get these subchondral bony cysts. So loss of cartilage, eburnation, thickening of the bone, sclerosis of the bone. These are the classic things you can look for. At the edges, you start getting outgrowths. They'll start growing out like this. This will be called an osteophyte when it grows out at the edges. Now we're going to compare this to rheumatoid arthritis, which is an inflammatory process. This starts with the synovium. The synovium gets inflamed and starts to proliferate. And it proliferates and proliferates, that's cool. Proliferates fine. Then it grows over the joint. Oh, that's not good anymore. When it grows over the joint and covers up the joint, we give it a fancy name, we call it a pannus formation. So, synovitis, pannus formation. Now, what is a pannus really? It's inflamed synovium. It's got a lot of granulation tissue, it's trying to heal. So it's gonna turn to a scar. Now you just scarred the joint. That is called fibrosing ankylosis. Ankylosis is fusion, and it's due to fibrosis. From the pannus, it's inflamed granulation tissue. It heals with scarring. Now this joint is not going to move properly. In fact, if it's fibrosis here, what do scars do? They contract. So when this contracts on itself, this joint will now be pulled that way. You're going to start getting deviations. These are classic deformities you'll see in rheumatoid. Yeah, the wrist is going to go radially, and the MCP are going to go ulnar. They're going to deviate because of this scarring, contracting the joint on one side more than the other. Make sense? So again, this is the 3 lesions you need to know. Synovitis, pannus formation, and then ankylosis. First it's going to be fibrous, and then it's going to calcify and literally become bone. That's called a bony ankylosis, when the fibrous tissue becomes calcified. Now that joint ain't going to work at all. That joint is fused. So it gets deformed, and then it becomes fused and fixed, and you can't really move it. You can't really use that joint much at all. So these are the classic findings of rheumatoid. Now, rheumatoid is one of those topics where I can write 1,000 questions and not run out of questions. There's so many things to ask here. So make sure you know rheumatoid pretty well. It's a chronic systemic autoimmune disease, so it's going to be more common in women, but men can get it too. And it can involve many organs, not just the joints. So lung disease, heart disease, and that can wind up killing them. But I want you to remember, it's usually joint involvement where you have an inflamed synovium. So that's what's going to lead to the destruction of the joint. This inflamed synovium grows over the joint, then you get ankylosis, fibrous, and bony, and you destroy the joint. Now, it's a pretty common condition. And it's about 1% of the population, and it's females much more than males, usually reproductive age. That's when you see it. Now, you guys are too young to know, but there was a woman called Kathleen Turner. She was in Romancing of the Stone, a pretty famous movie, where Kathleen Turner used to smoke, and she wound up getting rheumatoid arthritis. Really bad case, too. So, women, reproductive age, that's when you get to see this. Now, with most autoimmune diseases, genetics do play a role. You usually have to have the right HLA. So this is associated with different HLAs, DRB1, which also is part of DR4. So watch over DR4. So HLA DR4. Now let's see, for DR4, what did we have? We had giant cell temple arteritis. Remember temple arteritis was DR4? We had type 1 diabetes. Type 1 diabetes was DR3, DR4, or having them both together. So just a couple of diseases that are DR4 associated. Now, it also can involve polymorphisms of the PTPN22 gene. Remember, this is one of those inhibitory genes for regulating T cells. Well, if you don't regulate T cells, well, then your immune system can get out of control and attack you. So this is pretty common for a lot of these autoimmune diseases. We're finding certain polymorphisms of this regulation of T cells seem to increase your risk. Okay, so polymorphisms of this gene. All right, now just because you have the right genetics doesn't mean you're going to get it. Not everybody with DR4 is going to get this. So what's going to be the trigger? Something in the environment. Now, smoking is highly associated. Kathleen Turner was a smoker. So smoking may play a role, infections may play a role. And here's the reason. When you smoke, or if you have infections, you create inflammation. That inflammation can cause citrulline of some of your amino acids, and therefore you can create new antigenic epitopes. You can create new antigens that your immune system may start attacking. And that's what may trigger the autoimmune response. So again, smoking causes citrulline, infections and inflammation causes citrulline, and it can create some cell proteins, some antigens in your body can now be created that you can start attacking. Now, what is this citrulline exactly? Well, it's basically a reaction where the normal amino acid arginine gets post-translationally modified. In other words, you've made it, arginine, beautiful, and then it gets modified after it's been already made. It gets modified because of the inflammation in smoking, and basically becomes deaminated, which basically you take like a nitrous product off of it. So when you do that, you create an amino acid, which is not normally made by the body. This is called citrulline. So this is called citrullination. You're taking arginine, taking a nitrous group off it, and creating citrulline. Now these citrulline molecules will tend to make what's called cyclic or loops that can create new antigens. So let's repeat. Cyclic citrulated peptides are produced during inflammation, such as infections and smoking. So here's the arginine, and because the inflammation, it gets converted to citrulline. So we just took this off here. Took it off, put oxygen there instead, and took it off, now it's citrulline. Now this citrulline is going to induce these formation of these cyclic, so you made like a loop here, make a loop, and this creates a new antigen that your immune system may attack. Now, most people won't attack it. Most people smoke, they don't have any problems. But if you are smoking, you create these, and you have the right HLA, you have a risk of now creating a self-reaction. That's what we think it is. Patients with citrulline have increased risk of, I can't see what you're writing. I'm on a new computer, which is really small. Citrullinemia. I don't know what citrullinemia is. Honestly, I don't know. Is that a biochemistry disorder? I don't know. I've never heard of it. There's no pathology biopsy for that. I'm going to have to Google that, Kevin. You got me stumped on that one. I don't know. All I know is smoking induces this modification of arginine to citrulline. So again, I'm going to have to Google that because I don't know what citrullinemia is. Honestly, I don't know. All right, so unfortunately, this is going to create new antigens, and you can now create autoimmune reactions. So remember the term citrullination. All right, now this is a multifaceted process here. First, we have to have the right HLA. Then we have to be exposed to some sort of environmental factor, smoking, infection. That creates citrullination of cell proteins. Now, if I have the right HLA, and I've got this right thing, and my immune system fails to regulate itself, now I can attack myself. I can get T and B cell responses to these self-antigens, okay? Antigens usually in the joint tissue. Now you're gonna get T helper 17 cells. So remember what they do. They make interleukin 17, which calls in neutrophils. So there will be some acute inflammation here. You're also gonna get T cytotoxic T helper 1, sorry, that's not cytotoxic, that's helper. T helper 1 cells, what do they make? They make interferon gamma. And interferon gamma can turn on a lot of different cells to proliferate. And then of course, B cells will also be activated, so you're gonna make antibodies. You're gonna make antibodies called rheumatoid factor and antibodies called anti-cyclic citrulated peptide antibodies. Those are the antibodies attacking those citrulated peptides. Now, when I was in med school, all we had was rheumatoid factor. So they really like to ask this one. Rheumatoid factor is an IgM. So notice it's a pentamer. 1, 2, 3, 4, 5. It is 5 different antibodies being held together by a joining chain. Now, what is the target of this IgM? Well, its target is the Fc portion of IgG. So the target of this antibody is it's attacking the Fc portion, which is down here. So this is Fc, this is FAB. It's the antigen site. It's AB. So this is an IgM whose target is IgG, the Fc portion. So that's kind of like confusing, right? It's an IgM, but its target is IgG. Now, do you think this could form immune complexes, get stuck in vessels, and cause vasculitis? Probably. Probably can lead to a vasculitis here. You know? Now, when I was in med school, this is all we had. So we would measure this to help confirm the diagnosis. But it's nowhere as good as anti-CCP. This is the new sexy one because we're making antibodies against this citrulated peptide. So anti-CPTB, these are horse specific, and the level corresponds with how severe it is. So the higher the level, the more erosive bone problems they're going to have. So this is very important to look for CCP. So if they're both a choice, go for CCP. And for some reason, I think of the Russians. Do you remember they were called the CCCP, former Soviet Union? CCCP, the Russian hockey jersey always had CCP. And of course, RF, Russian factor. RF, the Russian factor. So I was over Russian factors and CCCP. Oh yeah, those are the antibodies for this. It's like the Russian ones. And the Russians are to blame for everything. So we got T helper 17, we got T helper 1, we've got B cells making antibodies. Now what's going to happen because of these interleukins and this interferon, you're going to get a proliferation of fibroblasts, chondrocytes, and synovial cells. This is that synovitis. It gets inflamed, it starts proliferating, macrophages are going to join in, you're going to get more inflammation, you're going to release all these enzymes like collagenase and stromolysins and elastase. This is going to start damaging and inflaming all the synovium. And this inflamed synovium will proliferate and grow over the joint like a claw. They call it a pannus. And unfortunately, this will now cover up the cartilage and cause degeneration of the cartilage. It'll also push on the bone, and you'll get bone erosion between these inflammatory mediators. Do you remember osteoclast activating factors, interleukin 6, interleukin 8, interleukin 1? So you're going to get some bone erosion here too. Okay, so the synovium gets inflamed. As it's growing over the joint, it's going to cause erosion of the bone, especially at the edges. So if I draw my bone here, let's draw a small joint, shall we? Let's draw some small joints here. Here is your joint capsule. Okay, now the synovium should be over here. So it's going to start proliferating. As it proliferates this way, it will start to grow over the joint. Now over here, it's going to start causing erosions of the bone. They often describe them as rodent ulcers, or rodent ulceration of the bone, where you get these little lytic lesions at the end, look like a rodent came in, took little bites out, like rat bite erosion. So the bone literally becomes eroded, becomes osteopenic in this area because of the inflammation, the inflammatory process. And then again, the synovium will grow over the joint and then cause ankylosis and fusion. That's the problem. It's going to destroy the joint deformities. Okay, now 3 classic pathology. Synovitis. It's often chronic and papillary because it's a chronic autoimmune disease. It becomes papillary over time. So if you look at this inflamed synovium, do you see how many purple dots there are? That's a lot of inflammatory cells. I'm starting to see germinal centers here. I'm seeing a chronic inflammatory process. And do you see the papillary structures? This inflamed synovium is really becoming very papillary. Under the microscope here, the synovial cells And look at all the chronic inflammation. You're seeing blood vessels. This is like inflamed granulation tissue now. This is going to heal with scarring. So again, we're looking for chronic inflammation, a little bit of acute inflammation, and inflamed synovium, just growing over the joint. That is called a pannus. Pannus means claw. So it's a proliferation synovium with granulation tissue, and it grows over the joint. Then it becomes fibrotic, becomes fibrosed. That's called fibrosing ankylosis. Then it becomes calcified and becomes bone. And again, if this side is involved more than this side will become contracted, and the joint will literally become deformed, will be pulled to one side. Okay, so these are the three classic lesions: synovitis, pannus, and ankylosis. On the x-ray, the joint is going to be swollen. You'll see an effusion here. It's inflamed. It's an inflammatory process. You'll see osteopenia and those rat bite erosions from the inflammation and activation of osteoclasts. You'll see narrowing of the joint space as you wind up destroying the cartilage. It's destroyed. And loss of the articular cartilage. All right, now the clinical. We're looking for a symmetrical polyarthritis. Multiple joints are involved, and it's symmetrical. Usually involves small joints, so look for these, the small hands, the joints of the hands, the feet, ankles, the wrists. Now the most common sites are the PIP and the MCP. So MCP, the knuckles where you punch somebody, knuckles, and the PIP. DIP, that's usually, if you hear DIP, think about degenerative arthritis. But rheumatoid can involve any joints, but MCP and PIP are very common. Now, what do they look like clinically? Well, they're going to be warm. They're going to be swollen. They're going to be painful, especially when you wake up. But here's the key. They're stiff in the morning, but the more they use it, it loosens up, the better they feel. So I want your morning stiffness. Yes, gentlemen, that's normal. I'm talking in your hands. Morning stiffness in your hands, that gets better the more you use it. Now remember, did osteoarthritis have morning stiffness? Yes, but the more they use it, the worse it feels. It's the exact opposite. This one, they get about an hour of morning stiffness. After about an hour of using it, it loosens up and they feel better. They feel better. So they're stiff for about an hour in the morning, then they get better. Okay? Now notice, it is a systemic disease. So we're talking about joints here, but other areas are involved too. So you can have constitutional symptoms. You can have low-grade fever because of inflammation and malaise. And that's due to the inflammatory mediators like interleukin-1, TNF-alpha. And you can also get rheumatoid nodules outside of the joint. These are present in about 25% of cases. They're usually on the extensor tendon, so you'll see bumps right here, right by the elbow. These bumps here, they're called rheumatoid nodules. Now, if you biopsy them, well, it's immune damage. So what type of necrosis you're allowed to pick? Fibrinoid. So you'll see this pink necrosis, no nuclei, it's just dead pink stuff, surrounded by a bunch of macrophages and lymphocytes. So the macrophages are coming into dead stuff. So fibrinoid necrosis, that's either malignant hypertension or an immune disease when you see fibrinoid. So fibrinoid necrosis surrounded by a bunch of macrophages trying to eat it up and get rid of it, that's a rheumatoid nodule. By the way, they usually in the extensor tendons, but you can see them in the lungs. If you see them in the lungs, remember Kaplan syndrome. Kaplan with a C. Kaplan is anytime you have a pneumoconiosis and you develop rheumatoid. And they often get these rheumatoid nodules in the lungs. That's cool. Rheumatoid nodule in the lungs, that's not common, except in things like Kaplan syndrome. Right? Okay, now here are those deformities we're going to talk about. And this is really going to become very debilitating. When you get deformities, you can't use your joints very well. So when we talk about the wrist, I want you to remember wrist goes radial. Wrist goes radial. Wrist goes radial. MCP goes ulnar. Now again, I can't do it because I'm normal. But if you look here, notice the way the wrist is going radially. Wrist is going radial. And then the MCP is going ulnar. So that's the classic. The wrist goes radial. The wrist goes radial. MCP goes ulnar. Classic deformities. Now, when they get involvement of the PIP and DIP, they get what's called Boutonniere's deformity and Schwanneck deformity. depending on whether they're flexed or hyperextended. So boutonniere is flexion of PIP, extension of DIP. Schwann neck is hyperextension of PIP and flexion of DIP. So it looks like either a Schwann or it looks like a boutonniere. So these funny looking deformities. Again, classic. They show me this picture, no history is required. And look at the x-ray. Do you see the deviation? This joint is really malaligned here. It really got pulled out of whack by this inflamed fibrosing granulation tissue. Got pulled out of the way. So these joints are not going to work very good. Luck opening up the door. It's going to be hard to open and use your hands. Not a great thing. Now, x-ray, we're looking for osteopenia. So notice the way the bones are getting very thin here. Very thin in these areas that are involved, very thin. And then you can sometimes see bony, like erosion. See right here, the bone is kind of missing, the missing area there. So you're looking for erosions, loss of joint space, and osteopenia. Those are some classic findings. But the deviation, look at the deviations. They're like easy to see. All right, now, why is this 10 stars? Because of all the cool associations. We talked about the deformities, we talked about the joint pathology, but there's other problems too. Like we talked about the rheumatoid nodules. How about Baker's cysts? These are cool. These are synovial cysts that occur in the popliteal fossa. We call them Baker's cysts because Bakers, we get them. Right? Bakers, we keep having to go down in the oven, right? You have to go down and have to go down. Well, behind their knees, they would get these cysts from all the physical trauma. Keep going down to put things in the oven. So they call them Baker's cysts. But they get them here too. These cysts in the synovium in the back there. Okay. What else? They can get necrotizing vasculitis. Remember we talked about the IgM against IgG? You form these large immune complexes. They can deposit and cause a vasculitis. What else? You can get Sjogren syndrome, and that's a pretty strong association. So about 15% of rheumatoid patients will get dry eyes and dry mouth. Vice versa is even stronger. If you have Sjogren syndrome, about 60%, more than half, will get rheumatoid. So if you want to be Dr. House, you got to know associations. You got to know the associations. Very important. All right, now what about Felty syndrome? How was about this? I felt the spleen. I felt the spleen. So Felty syndrome is whenever you have rheumatoid arthritis and you develop a big spleen. Now, big spleens get hungry. What do? They eat. They eat your neutrophils. So now you're at risk for bacterial infections. So that's Felty syndrome. They usually come in with bacterial infections, and then you palpate a spleen. Remember, you should never, ever palpate a spleen. If you can palpate a spleen, that's splenomegaly. So rheumatoid plus a big spleen and neutropenia, I felt the spleen. That's Felty's. Now, Kaplan syndrome, we mentioned already, it's very high yield. This is rheumatoid arthritis that occurs in any patient who has a pneumoconiosis. So it could be a coal miner, it could be a shipyard builder because of asbestosis, could be silicosis, could be brilliant berylliosis. If you have a pneumoconiosis, and then you develop rheumatoid nodules in your lungs, you've got Kaplan syndrome. You develop rheumatoid arthritis in your joints. All right, now since this is inflammation, you're at risk for secondary reactive, the AA form. And it's pretty common. In fact, it is the most common cause of reactive amyloidosis. It's the most common cause of secondary reactive amyloidosis because it's a chronic inflammatory disease. You live a long time with lots of inflammation, high risk of developing. Now, treatments. We're going to try steroids. Those are always important for players. But we also want to do synthetic or biologic disease-modifying drugs because steroids is only a temporary stop of the inflammation, doesn't really change the course of the disease. So we want to do things like methotrexate to kind of like knock your immune system down, or this is a big one, TNF inhibitors. Very important for refractory cases. TNF inhibitors, things like infliximab, because TNF is one of the major inflammatory mediators here. So very important to remember TNF inhibitors. Make sure you check for TB first. Check for TB first. Very, very important. All right, now we're going to compare everybody to degenerative arthritis and rheumatoid. Now again, degenerative, the joint tap is non-inflammatory, but inflammatory, it could be rheumatoid arthritis or the seronegative spondyloarthropathies, because these are inflammatory. So these are going to be very similar spinal taps, sorry, joint taps, I should say, joint taps. So when you do arthrocentesis, the RCT is very similar. So your job on the exam is to tell the seronegative diseases from rheumatoid, because they can look similar. So first clue is they're seronegative. That means no rheumatoid factor and no CCP antibodies. So that's the first clue. It looks like rheumatoid, but it's seronegative. Number two, it's due to HLA-B27 association. Oh, that's right. Rheumatoid was DR4. These diseases are B27, different HLA. Okay, nothing these have in common is they all involve the sacroiliac joint. Sacroiliac joint, very commonly involved in these seronegative diseases. And then finally, these are going to be asymmetrical. Rheumatoid is usually symmetrical. These are asymmetrical. So again, this is a group of 4 inflammatory joint diseases that are going to be seronegative, rheumatoid factor and CCP is negative. They're going to be B27 positive. They're going to involve sacroiliac joints and other joints too. And they're going to be asymmetrical. That's what they have in common. And there's 4 of them. Ankylosing spondylitis is going to be your highest yield, followed by reactive, formerly known as Reiter's arthritis. Those are the 2 highest yield. But there's also psoriatic and enteropathic, which is basically inflammatory bowel disease associated. So enteropathic, enterointestines, IBD. So some people call it pair. The pair diseases, P for psoriasis, A for ankylosing spondylitis, the I for IBD, enteropathic, and the R for reactive. That's just a way to remember these are the 4 seronegative ones. Now, for you, you better know the first 2. First 2 are like 10 stars on a 10-star scale. They love these. So let's start with this first one. Ankylosing means fusion, right? Fusion. Spondylitis, inflammation of the vertebrae coming off the vertebrae. So ankylosing spondylitis, fusion of your spine and sacroiliac joints. Another name for it is Marie-Struppel disease, another name. Now this is the most common of all of the seronegative diseases, so you have to know it. Now it's a chronic synovitis that causes destruction of the articular cartilage, and it's going to lead to bony ankylosis of the sacroiliac joint. So if you look down here, you're supposed to be a sacroiliac. There should be a line here. There should be a line here. It's basically fused. I can't really see where the I think it was supposed to be right here where this white thing is, but it's basically gone. They have fusion of the sacroiliac joint. Well, not just the sacroiliac joint, but also the lumbar vertebrae. So the lumbar vertebrae become squared, they become fused, they start to look like bamboo. So if you take a look at squared, short things, it looks like bamboo. They're all fused, ankylosed. So these are classical bamboo spine. Now remind me, if I say a teenage male is having stiffness and lower back pain, now I said 72-year-old has back pain, well, they're old, right? This is a 20-year-old. They're way too young to have arthritis. So here's what they usually complain of, doctor, I can't bend over, I'm really stiff. I can't bend over. You try to make it, they can't, they're getting all fused here. So lower back pain, and they're really stiff, they really can't bend. Now what they often ask is what HLA is most likely going to be found in the patient if you look for it. B27. So what they tend to have in common, they tend to have B27 positivity. Now, do you need that for diagnosis? No, but it's something the board likes to ask about. B27 seems to be a big risk factor for this. Okay, so remember those bamboo spine, guy with lower back pain and stiffness. Now the next one is also equally testable. It's called a reactive arthritis. John, what are you reacting to? I'll show you in a second. An older name for it is Reiter's syndrome, but we don't want to call it that because Reiter was a Nazi, and we don't like Nazis. Don't like them. So I know in all the books it still says Reiter's. People on the wards are going to call it Reiter's too, but to be PC, we're supposed to call it reactive arthritis. So let's call it both. So we'll remember reactive Reiter's arthritis. Now, there's a classic triad here. You can't see, you can't pee, you can't climb a tree. You can't see, you can't pee, you can't climb a tree. Okay, can you see? Yeah. But you can have red eyes, you can have conjunctivitis. You can still see, but you can have some eye pain and some red eyes. Can you pee? Yeah, you can pee, but it hurts. It hurts. You get a non-gonococcal urethritis. Pain on urination, gonna hurt. But you can still pee. So you can see, you can pee. Can you climb a tree? That one's true. You can't climb a tree because you have an arthritis of your ankles and knees. Good luck climbing a tree without your lower extremity, unless you're Nicole, who's an American Ninja Warrior. They're using all upper body to climb, right? But unless you're a Ninja Warrior, you need your ankles and knees to climb trees. So that one's the only one that's true. So they call it can't see, can't pee, can't climb a tree to remind me of the areas involved, but the only one of those that's true is the arthritis. It's hard to climb a tree without your ankles and knees. Now, clinically, it's usually young males, 20s and 30s, who are sexually active. Why am I saying sexually active? Because it's B27 positive, but there's got to be some sort of trigger. What the trigger often is an STD. Yeah, an STD. Chlamydia. Yeah, and that can also be triggered by bloody diarrhea, Shigella, Yersinia, Campylobacter, Salmonella, but chlamydia. Now take a look here. Reactive. What do you see right in the middle of the name? Chlamydia trachomatis. That's why it hurts to pee. They got chlamydia infection. Does chlamydia give you conjunctivitis? Oh, yeah. So this is often triggered by chlamydia. But again, it can be triggered by bloody dysentery as well. Now notice they also get lower back pain because they get the same involvement of the sacroiliac joint. They just don't get a bamboo spine. They don't get the bamboo spine. They get more of the arthritis of the ankles and knees more. Okay, so remember STDs, chlamydia trachomonas, and reactive CT. There it is, chlamydia trachomonas, right there. They're reacting to chlamydia. That's what you're reacting to if you have the right HLA. All right, now another cool feature, and by the way, I should have told you to get the kids out of the room. Sorry about this. Some cool features of reactive arthritis is they also tend to get a very famous rash on the penis. Notice it's very well demarcated and very serpiginous. It kind of snakes back and forth. So this gets a very fancy name. They call it circinate balanitis. Inflammation of the glands of the penis in this serpentine fashion. Very classic rash. So they have pain with urination, and they got this really cool rash. Now they also tend to get these lesions on the bottom of your feet. Look at these things. Yeah, this is called keratoderma, can't even say it. But these are some hallmark features. So get these in your memory bank. Remember, chlamydia trachomonas, can't see, can't pee, can't climb a tree. But in addition, they get this funny rash in their private parts, and they get this funny this keratodermatitis here. Blenneragicum. So they look like hemorrhagic blecks. I don't know what the heck that bleck is, but that's what they call it. All right, now these last two are much lower yield. Why? Because if you have psoriasis and then you develop an arthritis, I think it's a psoriatic arthritis. So remember who's got psoriasis. Do you remember Kim Kardashian? I don't know her HLA, but if she is B27 positive, about 10% of patients with psoriasis will get arthritis if they have B27. So she's got a risk. If she's B27 positive, about 10% risk of getting this. Now, some unique things. They tend to get sausage digits. they get what's called dactylitis. They get these inflamed joints that become like sausage fingers, sausages. So about half of the patients are going to get this dactylitis. So remember, sausage fingers. Now, what does the P stand for? Well, that stands for the X-ray. The X-ray is going to have a pencil in a cup deformity. Pencil in a cup and sausage fingers. Now, what the heck is pencil in a cup? Well, normally, one joint should kind of go into the next joint really nicely. But what happens here is this tends to get really narrow like a pencil. This part's still okay. It's like the cup. So a pencil sitting, it's like you sharpened it, you put it in there. It's like a pencil going in a cup. This is a very classic deformity. It's only there about 30% of the time, 40% of the time, but it's a classic finding. So about half the time, I guess. So I want you to remember psoriasis, they're gonna have a history of psoriasis, they're gonna have a pencil in a cup on X-ray, and they're gonna have sausage digits, very classic. Now, under the microscope, it looks a lot like rheumatoid arthritis, but it's less severe, and you don't get the classic deformities you get in rheumatoid. You just get this pencil and cup deformity. So you go from normal to this narrowing here. And of course, the last one's also very easy, because if you have inflammatory bowel disease and then you get arthritis, we're going to call it enteropathic arthritis. So this is one of these spondyloarthropathies, seronegative, that's associated with inflammatory bowel. Could be Crohn's, could be UC. Now remember, which one of these is B27 positive usually? Oh yeah, ulcerative colitis. This is very commonly B27 positive. So very high, more likely to occur with ulcerative colitis. All right, what else can do it? It can also be triggered not just by inflammatory bowel disease, but enteritis can do it too. So any of the GI infections that are bloody, like Yersinia, Salmonella, Shigella, Campylobacter, they can also do it too. They can create these lipopolysaccharides that stimulate a host response, where you can get this rapid onset of arthritis, usually in the knees and ankles. So again, it's due to a bowel disease, either inflammatory bowel disease or a bloody diarrhea, infectious diarrhea. Okay, so that's enteropathic. All right, now we did the two biggies, osteoarthritis and rheumatoid arthritis. Then we talked about the four seronegatives. Now we're going to talk about crystal-induced. Again, this is going to be inflammation, because the crystals are going to be chemotactic for neutrophils. So neutrophils are going to come in. It's going to be an inflammatory arthrocentesis with the tapping. But you're also going to see the crystals too. So very important to tap the joint and look for the crystals. So we look for gout and pseudo-gout crystals. Okay, so let's make sure we can tell them apart. Okay, let's start with gout. Gout is excessive amounts of uric acid. Now here's the key. You can't just have high uric acid in your bloodstream. That's not good enough. I know a lot of people with high uric acid and they don't get gout. So you have to have high uric acid, and then it has to deposit in your tissues as crystals. That's how you get gout. You have to have high uric acid, and then it has to deposit in your tissues. Then you get gout. Because I know a lot of people with high uric acid, but they never get gout. It has to deposit. So one of the things that will make it deposit is if it gets super saturated. So if you become very dehydrated, if you don't drink a lot of fluids, you'll be at high risk for this. So we always tell those patients, drink a lot of water. Drink a lot of water. So supersaturation will lead to precipitation of monosodium urate crystals in your tissues. That's what leads to inflammation and pain. Now, it's pretty darn common. 1% of the population has it. It's much more common in males, and it tends to be older males. So we used to call this the disease of kings. The disease of kings. Bring me my red wine, my red meat, and my red women. All right, not the women part, but red meat and red wine. It used to be older males who could have whatever they want. So excessive alcohol. Why? Because in my kidney, I have a transporter to get rid of uric acid. But that transporter can also get rid of alcohol. So if you're drinking a lot of alcohol, it's going to compete for the transporter, and you're not going to excrete uric acid as efficiently. So that's why alcohol, and it doesn't have to be red wine, it's associated with red wine, but any kind of alcohol can kind of increase your uric acid because you can't get rid of it. What else? Obesity seems to be a risk. consumption of a lot of purine-rich foods, a lot of meats. Diabetes has been associated with metabolic syndrome because of inflammation. Obviously, renal failure because you don't excrete it. And then polymorphisms in the genes for transporting out of some of the uric acid crystals. That all makes sense. If your kidney can't excrete it, you're going to have trouble. Now, why is the uric acid high? Well, most cases are primary. It's due to overproduction of uric acid, or it could be under excretion. Most cases are overproduction of uric acid. So what drug are we going to put most people on because it's due to overproduction? Well, you want to inhibit xanthine oxidase. So allopurinol will be a classic drug to use here. Allopurinol because it inhibits the production. If it was due to underexcretion, well, first of all, how would I know it's underexcreted? Well, you'll know because serum uric acid is sky high, the urinary uric acid is low. Well, if the serum is high, you should have high in the urine. If the urine level's low, that means your kidney's not excreting it. There's trouble with your kidney. So then you want to give a uricosuric agent to help the kidney, something like probenecid. Probenecid will help with excretion. But again, the majority of cases are overproduction, so pretty much everyone we just assume overproduction. Unless we check the urine and we find out the urine level's low, we'll just start allopurinol for most people. Now, it can also be secondary. What could create more uric acid? Well, breakdown of cells. The more cells break down, nucleic acids from DNA get broken down to uric acid. So anything that increases the turnover of nuclei, so things like leukemia, like the acute leukemias, they're growing so rapidly, cells are dying. Myeloproliferative syndrome, like P-VERA, is notorious for gout. So any of the myeloproliferative syndromes. Chronic renal disease, that makes sense because your kidney can't excrete it. Thiazide diuretic, because this can affect the transport in the tubules. But the one they really like is Leishnaia, because it's got this really long enzyme deficiency. So we abbreviated HGPRT because it's such a long name. But here's what you need to know. Leishnaia is a problem with this enzyme, which is important for the salvage of purines. You want to recycle. You're not a waster. You want to recycle your purines and use them again. So this enzyme is important for salvaging and reutilizing your purines. If you knock out this gene, I can't salvage my purines. I can't reuse them. So what's going to happen? Well, now you're going to have to break them all down to uric acid. So you're going to get a tremendous amount of uric acid production because you can't recycle any of your purines. They all get broken down to uric acid. So that's not cool. And here's just a little bit more detail because this is a famous one for the USMLE because it's biochemistry pathology integration. Now, first of all, it's X-linked. So we know it's going to be males. Now they're going to have a deficiency of this really long enzyme, hypoxanthine guanine phosphorybosyl transferase. So we just abbreviated HGPRT. Isn't that like a Michael Jackson song? PRT? PRT? No, that's PYT. All right, I tried. So anyway, HGPRT. Home and garden pervert? No, that's not right. I'm trying to think. HGPRT. Private? All right, I'll think of something. Anyway, this is important for the salvage of purines. If you can't salvage them, you break them down to uric acid. They get such uric acid production that it's going to accumulate in their brain, and these kids are going to get retarded. They're going to get spasticity, and they're going to get self-mutilating behaviors. Would you like to know what that is? Going to medical school. A classic self-mutilating behavior. Is that not true? I mean, that's self-mutilation 101. That's a masochism 101. Welcome to masochism. Yeah, we're both in the club. Now, the classic self-mutilating behavior is they literally bite their lips until they start bleeding. Bite their lips, or they bite their fingertips. They literally bite the skin off. Not just the nails, they bite the skin down to the bone. So they're like grinding there. They're gnawing on their own bone. Man, that's nasty. What else can they do? They can bang their heads. Bang their heads. They're like the little head bangers. So they're banging their head on the concrete. This is what we mean by self-mutilating. They bite their lips. They bite their fingertips down to the bone. They bang their heads. These are classic self-mutilating behaviors. Oh, and by the way, they also get gout. Least of their worries, right? They're retarded, they're spastic, they're hurting themselves, and they also get gout. Just adds an insult to injury. So that's Leishmania. Now, let's take a look at this little diagram. Okay, having high levels of uric acid is not good enough. It needs to precipitate as urate crystals in your joint. It's got to deposit in your joint. Now, it can also deposit in your kidney. If it gets stuck in the kidney, we call that a gouty nephropathy. So you see uric acid stones, and it often leads to pyelonephritis. So you'll see urate nephropathy, uric acid getting stuck in the kidney. All right, now back to the joints. Here are the crystals. Now the problem with these crystals are they're chemotactic. Neutrophils will come in because they're going to activate complement. Complement is going to keep chemotactic. Neutrophils are going to come in. Now when neutrophils come in, they're going to eat the crystal. They're going to eat it. Now when they eat it, it activates the inflammasome. Do you remember the inflammasome? So when they eat the crystal, especially the macrophages, when the macrophages eat it, they start the inflammasome, which activates caspase-1. Doesn't cause apoptosis, no, this is different caspase. Caspase-1 is going to turn on interleukin-1, which is going to cause more neutrophils to come in. It causes more inflammation. So it becomes like a self-perpetuating thing. When the neutrophil comes in and eats the crystal, it makes more interleukin-1, which causes more neutrophils to come in. They eat the crystals, and the inflammation just keeps going and going and going. So again, this is going to cause more neutrophils to come in. They're going to eat the crystals. Now, when they eat the crystals, they're going to get activated. They're going to release all their inflammatory mediators to try to kill them. They're trying to break the crystal down. Then, unfortunately, they're going to die and release the crystals, and then the next neutrophil will come in and eat the same crystals, cause inflammation. So this is going to create a very painful inflammatory process. Inflammation, begetting inflammation, begetting inflammation. You're going to release all these enzymes, inflammatory mediators. You're going to get tissue injury and inflammation. And the most common site is the big toe. They call it podagra, the big toe. Usually at the metatarsal phalangeal joint, the MTP joint, metatarsal phalangeal joint. Okay, that's usually where they get it. And of course, this inflammation is going to activate osteoclasts. So you're going to get bone breakdown here too, because inflammation. All right, now let's talk about the different types of gout. If you have high uric acid, a lot of people do. They have what's called asymptomatic hyperuricemia. Again, no pathology yet until it deposits in your joints. So they can get these episodes where it deposits, and they get acute gouty arthritis. This is what we've been talking about. They get the subtle onset of this severe joint pain, swelling, and erythema. Now again, I see your red, sexy, painful joint. What must I do? You gotta tap it. You gotta tap it, man. You don't want to miss a septic joint. This is gonna look septic. Very painful. Looks like a septic joint. Now it's usually one joint on initial presentation, just like septic joints. They usually start out as one joint. Most common site is your first metatarsal phalangeal joint, so MTP joint. Yeah, the big toe, podagra. Now it usually lasts for a couple of days or a week or so and then goes away. So again, we don't know why. Maybe because you're dehydration, maybe because you use some alcohol, suddenly you get a painful, inflamed big toe, and then after about a week, the pain goes away. And this is so painful, by the way. You will see these patients, they won't put a sock on. They won't put a sheet. If you touch it with a sheet, they punch you because it is that painful. So I've seen people in the winter, they'll be all under the covers, really cold or under the covers, except their toe. Their toe is sticking out. That's actually not good because it deposits where it's cold. That's why it's very common in your extremities, because it gets cold there, and that makes it super saturated. So these poor people, they can't put the covers on it because it hurts too much. But if they don't keep it warm, it gets worse. Oh, it's like a catch-22. Now, after they get an episode, they can have a period where they're fine. This is asymptomatic intercritical gout, an asymptomatic period in between the attacks. They're fine. They're fine. They look great. Uric acid's still high, but it's not depositing the joints. And then long term, they can wind up with large collections that literally destroy the joint. This gets a fancy term. We call this chronic tophaceous gouty arthritis. You get these tophi in your toes that destroy the bone. Now, tophi, what's the definition? It's a large aggregate of uric acid crystals surrounded by intense inflammatory reaction. You'll see lymphocytes and macrophages and giant cells, and this is literally pathognomonic of gout. Large collections of uric acid. Now, the problem is, this is lytic. This is going to destroy the joint. This is going to destroy the bone. These are very destructive tophi. They literally destroy the bone and destroy everything. Not good, not good. Now, this is also going to cause inflammation and proliferation of the synovium. So you get synovial hyperplasia, so this can lead to a pannus, kind of like rheumatoid, and you can destroy the cartilage and now get degenerative joint problems. So not a good thing to have all this inflammation in the joints. Now, here's a good example of a painful toe. Now, why did I amputate this toe? Do you see the toenail, by the way? Do you notice the way it's black? Because inside, when I cut it in half and I look inside, do you see this large collection of uric acid? This is a chronic tophus, a large collection of gout. And this got so big it destroyed the bone. The bone is gone. It destroyed the arteries. So they got gangrene of the toenail. That's why we actually amputated, because of the gangrene. Because they're very destructive. Under the microscope, you'll see this large area of collections. Now, if you use polarized light, you'll see they're needle-shaped crystals. I can't see it here. I could just see this fluffy thing. These are all the crystals just piled up, piled up, piled up, just piled up there. And again, the most common site is going to be your MCP joint. So MTP, I should say, tarsal, metatarsal. That's the most common site. All right, now, here is the classic picture for exams. I'm going to stick a needle in, I'm going to suck it out. Now, do you see in the background all the neutrophils? Do you see all these segmented neutrophils? There's a neutrophil, neutrophil. See these segmented cells? So this is very inflamed. This is an inflamed joint. This is an inflammatory arthritis, okay? This is not inflamed. It's inflammation like crazy. No wonder it's so painful, exquisitely painful, because these crystals are chemotactic for the neutrophils. They come in, they create more inflammation, and it gets worse and worse. Now, what do the crystals look like? Needles. Needles. And they're negatively birefringent. So I just remember gout is negative needles, negative needles, negative needles. Now, John, what is this birefringence about? Two colors. Birefringence means two colors. Now, negatively birefringent, and by the way, you don't need to know this, but I'm going to tell you because it's cool. When I look for birefringence, I'm going to use polarized light, which means I'm going to control which way the light goes. I can control which way the light is going. Light's a wave, right? So I'm going to control it using my polarizer. Now, when you line up the light with the crystal, what color is it when it's lined up? So I'm going to line up the light in this direction. So I'm lining it up with this crystal and this crystal. They're lined up. If they're yellow, when they're lined up with the light, we call it negatively birefringent. It's just a definition. So if I line it up with the light and it's yellow, you call it negatively birefringent. Now question, this one is not lined up, so it's got a different color. That's why they call it birefringent. If it's lined up, it's yellow. If it's not lined up, it's another color like blue. Make sense? So if it's lined up and it's yellow, negative. Question, what if I lined it up with the light and it was blue when you lined it up? Oh, that's called positively birefringent. So if you line it up with the light and it's blue, then you call it positive. But again, let me get rid of that because this is negatively birefringent. In fact, what would happen if I changed the light? What if I took it away from here and I made the light go this way? Well, if I lined it up, now this crystal would turn yellow and these would turn blue, because this is negatively birefringent. Whichever's lined up will always be yellow. That is the definition of negatively birefringent. Okay? So again, do I need to know which is part? No, you don't need to know. Just remember, negative needles is gout. Diagnostic, pathognomonic. This is all about sucking out the crystals. You gotta do the tap. You gotta look at these crystals. That's how you diagnose it. All right, now let's compare it to pseudo-gout. What does pseudo-gout have? Well, again, it's inflammatory, very similar, painful joint, but it's gonna have positively birefringent polygons. Positive polygons, meaning when I line it up with the light, so if I line it up with the light, it's going to be blue. And then this one's not lined up, so this one will be yellow. So again, what color is it when it's lined up when it's blue? You call it positively birefringent. Again, you don't need to know that. Just remember, pseudo-gout is positive polygonal shapes like rhomboid and rectangular. Positive polygons is pseudo-gout. Now, very important we recognize the crystals are the money because they're going to try to fool you. Pseudo-gout is most common in the knee. Knee. Older guys in the knee. Gout is most common in the big toe. So what are they going to do? They're going to switch them. They're going to switch them on you. They're going to say a guy comes in with a painful big toe, he's drinking alcohol, painful big toe, and you're like, oh, it's gout, it's gout. Then they say positively birefringent polygons. Oh, it's pseudo-gout. So whatever it looks like is diagnostic. So again, I don't care if I say I suck it out of your earlobe and it's negative needles in your earlobe, negative needles is always gout. And by the way, that happens. Gout of the earlobe because it's cold. It's cold there. So gout of the earlobe happens on USMLE exams. So I don't care where it is. Negative needles is gout, positive polygons is pseudo-gout. Know that as a fact. Now here's pseudo-gout. Pseudo-gout is also known as chondro, cartilage, calcinosis. You're going to see calcifications of the cartilage. So on X-ray, that's a lot different. Gout was destructive, destroys the joint, destroys the bone. Here you're going to see calcifications of the cartilage. Another name for it is calcium pyrophosphate crystal deposition. So calcium, you're going to see calcification of the cartilage. Good clue, good clue. Now, pathology, it could be disorders of overproduction or decreased breakdown of pyrophosphate. Makes sense, makes sense. Just like gout, either you make too much or you don't get rid of it. Now, these crystals, deposits of calcium pyrophosphate occur in the cartilage, usually in the menisci, or it can occur in the intravertebral disc or the articulating cartilage. So it likes to deposit somewhere in the cartilage areas. Now, large deposits can rupture, and that could create an inflammatory response. Neutrophils will come in, and you'll get the same episodes of inflammation and pain as gout. And it can also lead to joint damage. All the inflammation causes scarring. So again, not such a great thing to have. Now let's talk about secondary. What can cause it? Well, previous joint damage. If you damage the joint, you have a higher risk of getting calcification there. And then all the H diseases. So hyperparathyroidism, hypomagnesium, hypothyroid, and hemochromatosis. All these H diseases tend to have a higher risk. We're not sure why. Now, under the microscope, they're kind of like rhomboid or rectangular. They got all these polygonal shapes. So I remember positive polygons. And just like gout, they're usually older males, but they're most common in these. So that's a little different. Now I want to stop for a second. We have these two diseases and we have them contrasted. Know the crystals. But how do you treat both of them? Well, they're both acute inflammation. So when you come in with these acute episodes of a painful toe, you stop inflammation with NSAIDs. So always try NSAIDs first, non-steroidal anti-inflammatory, NSAIDs first. Ibuprofen, indomethacin, let's try some indomethacin. Try to stop the inflammation. Now, if that does not work, for gout, the next step is to paralyze the neutrophils by using colchicine. Colchicine. Yeah, it makes up the microtubules, the neutrophils can't move, so they stop coming in. So pretty big drug, pretty big gun. So we try NSAIDs first. If it fails, you go to colchicine. Now, what are we going to do to prevent this in the future? Because that's for acute painful joint, got to stop the pain. So NSAIDs and colchicine. Now, we also want to get allopurinol involved to try to decrease some of the production, and then check the urine. If the urine level is low, you might want to give probenecid. Probenecid is a uricosuric agent which will help the kidney excrete it better. Okay? Just some of the drugs you should know about. Okay? But again, remember, treat them both with NSAIDs first. NSAIDs first, then colchicine if the NSAIDs fail. All right, we're rocking and rolling. This joint stuff is cool. Now we're going to talk about infectious arthritis. Now this one's pretty easy. Infectious, we got bacterial, which is going to be a pyogenic infection, and we got Lyme's, and the board loves Lyme's disease. So let's do these real quick. Okay, for bacterial arthritis, it's going to be an acute suppurative. It's going to be pus in there, and it's going to rapidly destroy the joint. You're going to have permanent deformity. You're going to lose the function of that joint. You destroy the joint. So very important to never miss a septic joint. Painful red swollen joints, you got to tap them to make sure it's not massive. 100,000 or more white cells, all like neutrophils, like 80% neutrophils. You got to think about bacteria. So where did the bacteria come from? Well, most commonly it's seeding the joint from usually episodes of bacteremia. So you brush your teeth, some bacteria go in the blood, and then finally it winds up in your joint. Or it can also spread from an adjacent infectious area. So maybe you have osteomyelitis, it goes into the joint, or maybe you got soft tissue inflammation or an abscess, it can spread in there as well. Now, as I mentioned, my rule is for joints and bones, always go for Staph. Staph aureus, Staph aureus, Staph aureus, Staph aureus, Staph aureus, Staph aureus, Staph aureus. Now, of course, there's always exceptions to the rule. If they're really young, you want to think about H. flu. So Staph aureus, older kids and adults. For really young, think H. flu. But with the vaccination, we're seeing less and less of that. You get the HIV vaccine. Now, what if they're sexually active? Well, that's a very important one. Sexually active, you want to think about gonococcus. So adolescents and adults, sexually active, or if you're missing MAC. So you remember C5 through C9? So missing any of them, C5, C6, C7, C8, C9, you're going to have missing MAC complex, you're going to have a high risk of Neisseria. Now, sickle cell, we always think of that for osteomyelitis, but it could also spread into the joint, and you could get a septic joint with salmonella. And then strep can do it every once in a while too. But big one is staph. If they're sexually active or missing complement, think gonococcus. Now, clinically, this is not going to be a diagnostic dilemma. They're going to come in with a sudden onset of a painful, red, swollen joint. They're not going to be able to move it very much. It's going to hurt. It's going to be really swollen. They're often going to have systemic symptoms, fever, white count elevation. The SED rate is going to be elevated because they're really inflamed. Now, most commonly, it starts out with a single joint, usually a big joint. So knees, hips, shoulders, usually a big joint. And then it can move around over time, but it usually starts in one joint first. Now, the key is the aspiration of the joint. You got to tap it, and you're going to see POTS. Over 100,000 white cells, a large percentage are going to be neutrophils. So it's going to be very opaque, it's going to be creamy fluid that clots very rapidly because it's POTS. Makes sense? All right, now, is there a salad target? I see a bullseye. I see a target. That's the classic rash of Lyme's. Now, this is a 1-second diagnosis. You don't need any other testing. When you see this bullet target-shaped rash, you can't miss this. This is Lyme's. So this is due to the infection with a spirochete, Borrelia burgdorferi, which is transmitted via the deer tick, the Ixodes species. Ixodes. So you get bitten by Ixodes, wherever you get bitten, that's where you get the bullseye. It's like, ooh, dork here, dork, Borrelia burgdorferi, dork bitcha. That's where it gets injected into your body from that deer tick. So look for that classic rash. When you see that, you start treatment. The treatment for this Borrelia burgdorferi, doxycycline. Doxycycline. Every medical student should know about doxycycline here. All right, so treatment for a dork is doxycycline. Now question, does the Ixodes deer tick carry other infectious agents? Yes, it does. So that's a famous question. What else does the Ixodes species carry aside from Lyme's? Well, Babesia, babesiosis, babesia. And it also can carry human ehrlichiosis, human ehrlichiosis. Now they call it anaplasmosis, but Ehrlichio is the classic name. So again, if it carries more than one possible infectious agent, that's a very testable thing. So it can carry any one of these diseases. Now, where you get bitten, you're going to get that target rash. We call it erythema chronica migrans, and that's diagnostic. Now, unfortunately, it's not just going to affect the joint, but it can affect the heart. So very common to get heart block, heart block from this. And it can check the brain, especially the cranial nerve, seventh cranial nerve. You're going to get facial palsy, usually bilateral Bell's palsy. Now, anybody can get Bell's palsy, but bilateral Bell's palsy, you should get Lyme's right away. That's very classic. Bilateral seventh cranial nerve palsy, always think Lyme's. Now, in terms of the joint, this is going to occur in a large number of untreated patients, usually within the first 2 years of developing Lyme's. And it's the dominant feature of late disease. So we really got to identify this and treat this because you're going to get bad arthritis for the rest of your life. Now, it tends to be remitting, so it comes and goes, and it tends to be migratory. That's very characteristic. Large joint, moving around. Large joint, moving around. So whenever I see a migratory large joint arthritis, Lyme's disease is one of the things I think of. Another thing you should think of when you hear large joint migratory, you should think about rheumatic fever. That also can have large joint migratory. Another thing you might want to think about dissection act is gonococcus. Gonococcus involves large joints and it can move around. So in terms of infectious diseases, gonococcus, Lyme's, and rheumatic fever all can have large joint that can move around over time. For them, it's usually knees, most common, shoulders, elbows. These are common sites. Now, under the micro, it looks very similar to rheumatoid arthritis. So it's a synovitis, looks very similar. And then, of course, the classic thing here is the infection induces autoimmunity. In other words, most of the pathology is not due to the spirochete. Most of the pathology is your immune system. You attack the bug, you attack yourself. We call it molecular mimicry. So if the bug looks like me, I'm going to get a lot of joint problems because I'm going to attack the bug, I wind up attacking myself. So remember that term molecular mimicry? We also start with rheumatic fever, very classic rheumatic fever. We see it also a lot with Chagas. Chagas, most of the damage is your immune system. It's not the Chagas, it's your reaction to it that damages self. Not cool. Molecular mimicry. You look like the bug, you attack yourself. All right, now a couple of miscellaneous conditions, and we're done with this section. And again, there's no really good place to put this, so they just put it here, soft tissue tumors. Now, John, what is my yield here? Slow, not very high yield here. But I still would be remiss if I didn't talk about soft tissue tumors. You're gonna need to know about them. Now, here's the rule. Superficial tumors are more likely to be benign. Deep tumors are usually sarcomas. So if I say deep, I mean retroperitoneum and thigh. So if you see a soft tissue tumor in the retroperitoneum thigh, bet on it being malignant. Bet on sarcomas. Okay, so superficial things more likely to be benign, deeper things more likely to be malignant, like liposarcoma. Okay? All right, soft tissue tumors, where do they come from? Well, they come from these pluripotential mesenchymal stem cells. So they're coming from a stem cell. So it's not a mature cell that goes bad. No, it's a pluripotential stem cell that turns malignant. So it's not a mature cell dedifferentiating, it's one of these immature cells. Now we classify sarcomas based on what they're trying to resemble. Are they trying to resemble fat? Are they trying to resemble muscle? What are they trying to mimic? What are they trying to look like? Now, benign tumors are much more common than malignant. The only exception for that is skeletal muscle. So for skeletal muscle tumors, the malignant ones are more common. But again, most of these are going to be benign. Now, incidence increase with age. As we get older, we're more likely to get it. And there are genetic syndromes that associate with soft tissue tumors. So we've mentioned a lot of these already. For instance, neurofibromas, we expect to see neurofibromas and schwannomas. These are two classic soft tissue tumors. What else? Gardner syndrome. Remember, you got osteomas of the jaw, polyposis. We also get fibromatosis of your abdomen. If you bark hard abdomens because of fibrosis. Li-Fraumeni. Li-Fraumeni is associated with very malignant soft tissue sarcomas. That's a P53 knockout, so that usually leads to very bad tumors, aggressive sarcomas. Oh, and by the way, the rule for sarcoma is chemo, radiation. They don't cure anybody. It's all about surgery. It's all about surgery with sarcomas. So if you can get it out, you can cure them. If you can't get it out, you're just going to palliate with radiation chemo. So not going to cure many people unless you can get it out. So we always try to go for cure if possible. Then we got Osler-Weber-Rondeau, which is the hereditary hemorrhagic telangiectasia. You get lots of these soft tissue telangiectasias, blood vessel tumors. Okay, now the first category tries to look like fat, and it does a really good job. It looks like mature fat, so we call it a lipoma, benign tumor of soft tissues, and it is by far the most common soft tissue of adults. And if you're going to be primary care, you're going to see these. People are going to come and say, Doc, I got a bump here. Now, do you think it's like really soft? It should be, right? It's fat. They actually feel a lot firmer than you would expect. I was very surprised. I felt it. I was like, oh my God. Like it's a lipoma. But I was like, it feels kind of hard. I think it would be squishy like fat. No, they're kind of firm. They're kind of a little on the firm side. They're not rock hard. No. But they're firmer than you would expect. I was a little surprised. I thought they'd be a lot squishier like I expect fat to be. Now, it's a benign tumor fat. And clinically, since it's benign, it'll be mobile. You'll be able to move around. It's slow growing. And of course, it's not going to hurt. It's benign. It's not invasive. Now, when you take it out, it's soft, yellow, and well encapsulated. So notice the way it kind of shelled out very beautifully. It just shelled out really nicely. It's nicely encapsulated. Now, under the microscope, it looks like mature adipose tissue. It looks like mature adipocytes. Notice it's hard to see the nuclei, kind of inconspicuous nuclei. That's very classic, the more normal fat. It's mostly fat droplets, kind of hard to see nuclei. Now, the treatment is excision. You take it out, you're cured. And again, you're going to see this coming into the family physician saying, Doctor, what is this thing? And you're going to resect it right in the office and send it to your favorite pathologist and they'll say, congratulations, lipoma, you're all cured. Superficial things tend to be benign. That's good. Now, deep things tend to be bad. This is called a liposarcoma. So it's trying to be like fat, but it's not mature. It's very immature fat. So this is going to be aggressive tumor. Now, this is a malignant tumor that tries to resemble adipose tissue. It's most common in the retroperitoneum. Ooh, bad location for it. Or the deep soft tissues, usually of the thigh, deep in the thigh. So these could be very hard to resect because in your retroperitoneum, it can wrap around the kidneys, wrap around the aorta, wrap around your vena cava. Good luck trying to resect around that stuff. It could be very hard to get complete excisions on these things. So we don't like these. In fact, I think, I'm not sure, I'll have to recheck, but I think the mayor of Toronto had this. Do you remember the mayor of Toronto? The one who got caught doing cocaine on the mayor's desk? He was like on the desk, and they got him. His name was Rob Ford or something like that. Well, I think unfortunately the poor guy got a liposarcoma of the retroperitoneum. Needless to say, they couldn't get it all out. If you can't get it all out, they're going to die from this. So unfortunately, I believe it killed him. So not a good tumor to have, liposarcoma. Some people say that Chavez, the Hugo Chavez of Venezuela, he had a very malignant tumor too, and some people speculate it might have been a liposarcoma. Again, we don't know. Everything is secret, but we think it may have been a soft tissue tumor like this. Now, the one thing I want you to know about these is the term lipoblasts. If you want me to diagnose this, you have to show me a lipoblast. So for my pathology boards, I gotta recognize lipoblast. For your boards, you just have to remember, if I see lipoblast, that's sarcoma. That's a liposarcoma, okay? Because these are very immature. They actually resemble fetal fat cells. They look like fetal fat cells. You'll see this vacuoles that kind of indent the nucleus. The nucleus gets all scalloped and indented. So the nucleus kind of looks like this. It's like all scalloped and indented. So funny looking nucleus that's all indented. It's all kind of squished. Because they got all these fat vacuoles here. They kind of pushing on it. Okay, now there's different types, and we're going to go from the best one to the worst one. The best one is well differentiated. It makes sense. It's at least kind of behaving. So well differentiated. Usually has applications on 12q involving this MDM2 gene, which knocks out P53. P53, usually bad stuff happens when you knock that out. Now, a little bit worse is a myxoid or round cell liposarcoma. This one is a cool translocation. This was on my boards. They asked about translocation 1216, which basically is going to have a fusion protein, which is important for the differentiation of adipocytes. And then the worst one is pleomorphic. Pleomorphic is going to be the worst one because it's not behaving at all. So again, they're all bad. It really determines, can I get it out? But as you go down, they tend to be harder and harder to resect. Now, treatment, the key is complete excision. The problem is recurrence and spread to the lungs are common. Remember, sarcomas go hematogenous. So for sarcomas, you always check the lungs. That's where osteosarcomas go. That's where liposarcomas go. They go to lungs hematogenously. Okay, so liposarcoma, remember lipoblasts. Now, here's the classic example of a myxoid one. Why they call it myxoid? Because look at all this gags, this myxoid, this ground substance, this light tan or light bluish tissue. This is all gags, glycosaminoglycans. So making a lot of gags. Then you gotta look for these cells here, these lipoblasts. Here's one. Here's a better one. See the way the nucleus is kind of indented? It's kind of pushed in there. These are called lipoblasts. Here's a really good one. Kind of really indented there, indented. So the nucleus is kind of indented. Again, is the board ever going to show this picture and ask you what it is? No, I'm just showing for fun. I just show it for fun. They're not going to expect you to identify lipoblast. But this is what they look like. Myxoid tissue, so we call it a myxoid. Liposarcoma, because I see lipoblasts. Okay, you see lipoblast, liposarcoma. You see myxoid, you call it myxoid. All right, now, here's a reactive proliferation of soft tissue. Nodular fasciitis. So you think there's inflammation of the fascia? You think it's nodular? Creates a mass? Yep. So this is a self-limited reactive fibroblastic proliferation. Now the way it's going to present is with a rapidly growing solitary mass. So rapid growth usually occurs in young adults and it occurs on the forearm, chest, and back. The place you're going to get trauma. Forearms, chest, back. So you're playing football, you get hit, right? So look for preceding episodes of trauma because we think it's just an overreaction to injury, okay? Now, there is a translocation here. So is it really just a reaction or is there some gene problems going on here? Is this really like a benign tumor? So we see translocation 1722, which create a fusion gene, which may be causing this excessive proliferation. So again, I'm not going to get into the argument, is it a reaction? Is it a benign tumor? That's for pathologists to argue over at their conferences. I just want you to remember, patient has trauma, you get this nodular area of fibroblast proliferation. Think about nodular fasciitis. Now, under the microscope, you're going to see these plump, randomly oriented spindle-shaped cells. So elongated cells, very plump, going in different directions. Notice they're not really lined up in any particular fashion. Look at this plump one here. That's a really plump one. So going in different directions, not really lined up. Just kind of haphazard arrangement. And there's going to be the myxoid stroma because these fibroblasts are laying down gags. So you see this light blue myxoid tissue here in between. And it's very cellular, lots of cellularity, and there's lots of mitosis because it's proliferating. Now, what we do for these is you come in with a mass, we don't know what it is, so you're going to excise it. And when you remove it, it's cured. It usually doesn't come back. So again, is it a reactive proliferation? Is it really a well-differentiated tumor? Not sure, but we know if you remove it, you're cured. You're cured. Now here's another reactive proliferation. Myositis, muscle inflammation, ossificans. So inflamed muscle that becomes bone. Again, football players, because they get tackled a lot in their thighs. When you tackle somebody, you're supposed to go for the thighs. When you keep getting hit in the thighs and those big muscles, you're going to get inflammation. And you get these reactive, again, is it self-limited reactive proliferation? What is it exactly? We're not sure. But it probably is a fibroblastic response to injury. We see it a lot in young athletes, young adults, and it occurs after trauma to one of the major big proximal muscles of the extremity. So thighs is a common site, thighs. Now you're going to see a swollen, painful area, and it's going to be, over time it becomes painless. Over time it goes from painful initially to painless, hard, well demarcated. So doctor, I got hit here, it was hurting for like a few weeks, and now it doesn't hurt anymore, but it feels really firm here. Do you feel this very well circumscribed mass here? What is it, doc? Well, I don't know. Let's go remove it. Let's go take it out. When you take it out, you see a fibroblastic proliferation, which over time calcifies and becomes bone. What? Inside my muscle? Yeah, you're developing this bone formation. That's so cool. So again, this is probably a response to trauma where you get a lot of inflammation, it starts calcifying, and then over time becomes bone. Metaplastic bone in the middle of your muscle. Again, I'm gonna feel a mass, I'm gonna remove it, and you're cured. So kind of similar. The only difference between these two lesions is this one is just fibrous tissue, myxoid fibrous tissue. This one is fibrous tissue that becomes bone. So you change the name to myositis ossificans. It ossifies, becomes bone. Okay, now here's an interesting group of diseases. Fibromatosis. Fibromatosis. This is a group of fibroblastic proliferations that grow in an infiltrative fashion. So unfortunately, since they're very infiltrated, it's hard to know where they start and stop. So they tend to recur after you resect them because it's kind of hard to kind of infiltrate. Now they can be locally aggressive, cause a lot of fibrosis, but they don't metastasize. So it's like a benign fibrous proliferation. Now location is important. We have superficial forms and we have deeper forms. The superficial forms are usually occurring in the palms, so you get these contractures. You get what's called palmar fibromatosis, you get these Dupuytren contractures. They can also occur superficially in the penis. That's called Peyronie's disease. So these are superficial areas of fibrosis, okay? And again, Peyronie's, you want Peyronie's. Peyronie's is a painful curved direction. No, thank you. It's also been associated with phenytoins. So Dilantin, no seizure medication for me. I'll be fine, thank you. Now, for the deeper ones, we actually call it a desmoid tumor. Desmoid tumors. So these basically look like tumors. They're for fibrotic proliferations, but they look like a tumor. So these are large infiltrated masses. They tend to occur more in females in the teens to 30s. What happens to females in the teens and 30s in their abdomen? Could it be pregnancy? Stretching your belly and causing damage and irritation? Could be. So they usually occur in the anterior abdominal wall where your belly gets bigger when you're pregnant. We do see mutations in APC or beta-catenin, the same as you see in polyposis syndromes. So that's why this has been associated with Gardner syndrome. Remember, Gardner syndrome has mutation in APC or beta-catenin. It's one of the familial adenomatous polyposis syndromes. It's a dominant form. We get osteomas of the jaw, fibromatosis of the abdomen. So that's a big association for you to remember. Rock hard abs. Now on gross, it's poorly demarcated, very infiltrated mass of fibrosis, and under the microscope, it is bland. You'll see lots of fibroblasts. They look mature, they look fine, nothing malignant about them, arranged in these broad, sweeping fascicles, making fibrosis like crazy. So again, is it a tumor, or is it just a fibrous proliferation? It's probably a tumor, but it's a benign one. Now treatment. We're going to try to resect, but the problem is it often recurs because of its infiltrative pattern. But if I can get it all out, I can cure it. Again, it's very common in women, so again, it may be the stretching of the pregnancy causes activation of fibroblasts, then years later you come with fibrosis. See, I always wanted abs of steel. This might be one way for me to get it. Get fibrosis, hard abdomen. No, but you should probably get it from working out, abs of steel from working out. All right, now let's go to malignant. Fibrosarcoma. Sarcoma, it's a malignant tumor that exhibits fibroblast differentiation. So that's a sarcoma. Again, these are all coming from these pluripotential mesenchymal cells, but it's looking like fibroblasts. Now, it's most common in the deep soft tissues of the thigh, the knee, and the retroperitoneum. Again, things that occur deep are usually bad. They're usually sarcomas. Under the microscope, we're going to see malignant appearing spindle-shaped cells, but what's cool is they make this herringbone pattern. In fact, that's probably the only thing I want you to remember. Fibroblasts and herringbone. Now, do you remember a fishbone? The fibroblasts are going to line up like this, and they're going to line up like this, like a fishbone. Fishbone. So I think you can see it here. Some of these fibroblasts are going this way, some are going this way, like a fishbone. And then again here, it goes again a different way, and a different way. So you're getting this fishbone pattern. That's what you're looking for, herringbone. And again, that would be the buzzword I would want you to know. Fibroblasts in a herringbone, that's a fibrosarcoma. Now we're going to try to go for cure by excising it, but if you don't get it all, it commonly recurs. You can recur. And then it can spread to the lungs hematogenously. So 25% metastatic rate, that's not a good thing, because once it's in the lungs, it's very hard to cure this. So that's a fibrosarcoma, malignant tumor of fibrous tissue. All right, now we talked about some of the muscle tumors, and in terms of skeletal muscle, these rhabdomyosarcomas are pretty evil tumors, very testable. Rhabdomyosarcoma. Sarcoma is malignant, myo is muscle, rhabdo is striated muscle. And there's actually three forms. The embryonal form is the most common, embryonal rhabdomyosarcoma, but there's also alveolar because it looks like alveolar, looks like lungs. And there's also pleomorphic, which is horrible. Anything pleomorphic is never a good thing. Now, embryonal is the most important, and we've actually talked about it already. It's one of the most common soft tissue sarcomas in children, and it usually is composed of these primitive round cells that tend to become elongated. They become like spindly, and they become like strap cells or tadpole cells because they try to elongate and become like muscles. Now, they often create polypoid masses. So if they're coming out of the vagina, we give it a fancy name, sarcoma botryoides, because botryoides means grapes, grape-like masses coming out of the vagina. Now, it occurs in the vagina, it occurs in the bladder, it also occurs in the head and neck region too. But the vagina and the bladder are common sites for exam. Look for the polypoid grape-like masses coming out of a young girl's vagina. Under the microscope, all these tumor cells grow in a layer. Underneath the squamous epithelium, they're all growing in a layer. We call it cambium layer. Some of the cells will elongate and become like tadpoles or like straps, like belts. And you may see cross striations. Striated muscle should have cross striations. Common sites are vagina, the bladder, and the head and neck area. And these have the best prognosis of these tumors. If we can resect it, we can cure it. Okay? And again, here's what you look for. You look for these small, round blue cells. Some of these elongated. See these pink elongation here? This is a strap cell. This long, elongated pink thing is another strap cell. They're elongated. If we went closer, you might be able to see cross striations in it. But it's elongated like a belt or a strap. All right, now less common is alveolar. Alveolar, it's only about 20%, but it's kind of cool because it's got a translocation either 2 to 13 or 1 to 13, and it's going to involve PAX6 fusion with FOXO1 fusion protein. So for my exams, this is the kind of stuff they're going to ask me. I doubt if it will be on a step exam, but it's just kind of cool. It's got a translocation. Now, why do we call it alveolar? Because the cells are small, rounded blue, but they don't stick together. They're discohesive. So when they kind of fall apart, you get these spaces in here. See, these should all be sheets of tumor, but they kind of fall apart. So it looks like the alveolus now. These look like alveolar spaces. That's where it got its name, alveolar rhabdomyosarcoma. So it looks like a pulmonary alveoli. That's what this space looks like. And then pleomorphic is going to look ugly, undifferentiated, worse prognosis. So again, what should I know from my exam? I want you to know the vaginal, Sarcoma boichoides, the one with the grapes coming out. Don't forget muscle markers. It's positive for Desmond, good muscle marker, Desmond. Better than that, MyoD1, MyoD1. And of course, myogenin. These are all good muscle markers. Desmond, MyoD1, myogenin, good markers for muscle. All right, now, synovial sarcoma is kind of a misnomer. Yeah, I was like, oh, it must be a tumor of the synovium. Nope. It's next to a joint, so that's why they thought it was a tumor synovium, but it's not. It's kind of like fake me out. So a synovial sarcoma is not a tumor of the synovium, but it's close to a joint, so that's where it got its name, synovial sarcoma. Now this accounts for about 10% of all soft tissue sarcomas, so it's pretty up there. It's the fourth most common sarcoma in adults, and it's usually middle-aged adults. Now it occurs in the deep, soft tissues, usually around large joints. So that's why they thought it was the synovium, they thought. Usually the knee. Knee is a common site. So knee and hips, that's where you're going to see it. Now here's a translocation you must know. So it's not very common, but this is the one thing I would ask about it. It's got translocation between the X chromosome and 18, X18. And it's going to fuse the synovial sarcoma genes. SS is synovial sarcoma genes. Makes sense. They get fused, they become a transcription factor, and they're going to cause this to grow. So this is one of the translocations where I would expect you to know, but sarcovial sarcoma, is it a tumor sarcoma? Is it a synovial sarcoma, a tumor of synovium? I'll give you 18 more tries. So X18. I don't know, maybe X-Men? You turn 18, you get to be a true X-Men? I don't know. How am I gonna make this be? I gotta make a mnemonic here somehow. But X18, that's something I would know about synovial sarcoma. Clinically, it's gonna present like most sarcomas as a slow-growing, painless mass. It's gonna be soft and yellow and well encapsulated. Again, nothing unique here. Remember that cool translocation. Now, under the microscope, what is cool is it's biphasic. So biphasic means two phases. It's got an epithelial component and a spindle cell, sarcoma component. It's got both. So epithelial cells in glands, cords, or aggregates. So see this gland here? See the gland? See the gland? This almost looks like adenocarcinoma. Look at the glands. So that's the epithelial component. And then the rest of these spindle-shaped cells, spindle cells. So these are the classic spindle cells. So biphasic, not many tumors are biphasic. That's cool. So epithelial and spindle cell. So what's going to make this one unique is it's got the same marker for all sarcomas. All the mesenchymal tumors have Amentin. But what makes it unique is it also has epithelial markers. Keratin is for carcinoma. Epithelial membrane antigen, EMA, this is for epithelium. So it's got epithelial markers too. And that's what makes it, the positive epithelioid stains, make it unique and differentiate it from all other sarcomas. So again, 18, 18 is a synovium, X18, again, you need a better mnemonic. So X18, and it's biphasic. It's a sarcoma that's got epithelial components. Now, unfortunately, it is very aggressive. It's aggressive, it likes to metastasize. So we're gonna attempt cure by doing surgery. We're gonna add some chemo, but in general, chemo does not really do much. It's the surgery that's really your chance of cure. Okay, we did it. We did it. We finished the soft tissue tumors. We also finished the tape. I don't think I gave a break, did I? Yeah, it's a long time. Okay. Side question is 6-week effective treatment in patients with. That's a really good question. I don't know of any good treatment for Lesch-Nyhan. Kevin, you're really stumping me today. Now I got homework. Now I gotta go check that out and see if I can find out. What is it, Stump Barone Day? I don't know treatments. I'm gonna look it up and see. Biochemistry. I don't think there's any effective treatment for the disease. I think most people wind up retarded with self-mutilating behaviors. But anything that could decrease it, interesting. Well, I'm going to Google this and see if we find some treatment for it, because that would certainly be testable. Anytime we have a genetic disease with treatment, That is something that the board would ask. So I'm gonna check that out, Kevin. I'll get back to you. All right, I'm gonna end the tape here. Thanks for hanging out with me.